myasthenia gravis video, we will start off with a quick review of cholinergic or acetylcholine signaling, which I hope is a neurotransmitter you are already pretty familiar with, despite it being early in Block 6. Because if you recall, we talked a lot about acetylcholine and cholinergic toxicity versus anticholinergic toxicity back in Block 3. And I have included that Toxidrome video with this week's videos in case you need a refresher, which I would encourage you to take a look at. We also talked a lot about acetylcholine signaling in the parasympathetic nervous system throughout most of Block 3 in the GI tract, as well as in Block 4 with cardiovascular and pulmonary videos. So now in Block 6, we're going to focus on cholinergic neurotransmission regulating muscle contractions. Now, if you recall from the Toxidrome video, acetylcholine is the primary neurotransmitter made and packaged and released by cholinergic neurons and act on both muscarinic receptors and nicotinic receptors throughout the body. But today we are going to focus on our nicotinic receptors, which can be found on our muscle fibers. And our presynaptic neurons will be our motor neurons. And at our neuromuscular junctions, these are our primary receptors involved with motor nerve muscle communication, controlling our muscle contractions. And these receptors are ionotropic receptors, meaning they are ligand-gated ion channels. That, when bound by acetylcholine, leads to the opening of these channels and the influx of cations, like sodium. And this inward influx of positive ions will eventually lead to those muscle contractions downstream. So for the sake of time, we won't go over how we get from this influx of cations to our muscle contractions in this particular video. So if you remember, neurotransmitter signals have to have on-off switches to terminate a signal when no longer needed. Otherwise, muscle contractions could not be initiated appropriately. So for acetylcholine, this enzyme is known as acetylcholine esterase, which hydrolyzes acetylcholine to choline and acetate, terminating that signal in the neuromuscular junction. So the choline can then be taken up and recycled to make new acetylcholine, and together the release and hydrolysis ensures signals for muscle contractions are propagated and terminated appropriately. So moving on to our next slide. So now that we have completed our brief review of acetylcholine signaling at the neuromuscular junctions, let's talk about how this is related to the pathophysiology of myasthenia gravis. So myasthenia gravis is an autoimmune disease affecting these neuromuscular junctions and this acetylcholine signaling. And this is because of an inappropriate immune response, potentially due to a thymus abnormality. And this inappropriate immune response is mounted generally against the nicotinic acetylcholine receptors, and these are recognized as foreign. So the T cells recognize self. They promote the immune cascade down to the B cells, which become our plasma cells, to produce those anti-nicotinic acetylcholine receptor antibodies. And these antibodies bind the nicotinic receptors, prevent the binding of acetylcholine to interfere with muscle contractions, leading to muscle weakness and easily fatigued muscles. In addition to this functional block, the antibody recognition can lead to complement activation and mediate damage to the receptors, and membrane damage as well. And this can also lead to receptor internalization and degradation, so there's less receptors available, and muscle membrane morphologic changes. Now, as you can imagine, an inability to appropriately contract your muscles can lead to significant and serious consequences, ranging from ocular myasthenia gravis to generalized myasthenia gravis to even myasthenic crisis. But there are a number of pharmacologic options out there to help circumvent this autoimmune attack at the neuromuscular junction. So let's move to our next slide. And based on this schematic here, my hope is that you will be able to think of a few agents we discussed in many of our previous autoimmune related videos that are likely applicable here, as well as predict what other components of the schematic could be targeted with therapeutics. So our first agents we're going to discuss will be our acetylcholine esterase inhibitors, like pyridostigmine, for example, which will inhibit our acetylcholine esterase enzymes responsible for turning off that cholinergic transmission. So by inhibiting this enzyme, more acetylcholine will remain in that neuromuscular junction for longer, with the potential to find those nicotinic receptors, or think of it as hopefully sort of outcompeting those antibodies to find any open receptors to propagate this signal for muscle contractions. So while this effect is beneficial at the neuromuscular junction, if you think back to our toxidrome discussion in block 3, these acetylcholine esterase inhibitors come with a number of side effects associated with elevated acetylcholine levels in other parts of the body. So remember, acetylcholine binding our muscarinic receptors is the rest and digest response. And another way to remember this is through the mnemonic dumbbells. And remember, this mnemonic can vary a little bit based upon source, but generally our cholinergic toxic effects include diarrhea. Sometimes diaphoresis is here. We have urination. We have meiosis. We have bradycardia. We have bronchoconstriction. Emesis. Lethargy, lacrimation, and salivation. You may also come across another mnemonic called sludge, which is along these same lines. Also, if you think about this list of adverse drug reactions, you should be able to rationalize which comorbidities may require you to use these agents cautiously in. So adverse drug reactions will be of the greatest concern, but usually our GI side effects are the most common, and we will still have our antibodies attacking our nicotinic receptors. So now let's talk about immunosuppressive options, which likely may be needed if pyridostigmine, for instance, doesn't manage symptoms sufficiently as a first-line option. There are immunosuppressant options for myasthenia gravis. So we will not go over these in depth, as you have seen many of these numerous times in block 5, and their mechanisms of action and other important pharmacologic considerations will all still apply here. So our options include steroids for initial immunosuppression, but if they cannot be tapered down, because remember all of those long-term side effects, then agents like azathioprine or mycophenolate mofetil and others may be initiated. Or rituximab may become an option, because if this is an antibody issue, then that means there is B-cell involvement. And remember, rituximab will target our B cells via CD20. Additionally, an initial option for acute situations, like in those experiencing a myasthenic crisis, may be IVIG, which we discussed before in our organ transplant video, which makes sense, right? Because this is an antibody-driven issue. Remember, IVIG is pooled and purified IgG from human plasma and provides broad spectrum of neutralizing IgG antibodies, which one can flood the immune system, preventing immune recognition, and function as an anti-idiotype antibody, where the antibodies from IVIG recognize the nicotinic acetylcholine receptor antibodies and bind them, tagging them for clearance from the body. And this is one pharmacologic way to remove or deplete these problematic antibodies in acute situations. Again, same adverse drug reactions and pharmacologic considerations apply. Now, our last agent we will discuss in this video will be eculizumab, which, you guessed it, is a humanized monoclonal antibody to an immune ligand, specifically complement protein or C5. And now I'm sure you address complement activation in block 5, so I won't go into depth here, but just know this monoclonal antibody binds and inhibits C5 cleavage to C5a and C5b. And without this cleavage step, we cannot generate that terminal complement complex. And without this cascade, the nicotinic receptor antibodies cannot trigger complement-mediated destruction of the nicotinic acetylcholine receptors and the muscle membrane. So just like before, this monoclonal antibody will harbor similar risks as the others we have discussed previously in other videos, like hypersensitivity reactions, infections, and infusion reactions, etc. However, one thing to note with infections, there is a significantly increased risk of meningococcal infections in patients on eculizumab. So there is actually a REMS program to ensure patients are vaccinated prior to use of this agent. So the role of this monoclonal antibody is still unclear, but right now more for severe and refractory myasthenia gravis cases. So moving on to our summary slide. So that concludes our discussion of myasthenia gravis and the various pharmacologic options available. So I hope this video has reminded you of some of the agents we discussed in previous videos, but now applied in a very different context, and has introduced a few new agents. Also, you should be very familiar now with cholinergic signaling and cholinergic toxicity, and the components of the dumbbells mnemonic. And again, if you need a refresher, please visit the Toxidrome video